Assalamu alaikum viewers. Welcome to VTeach24.
Myself, Dr. GhulamUllah Lail, Assistant Professor, Medicine and Allied. Colitis is another cause of the bleeding. Ischemic colitis, inflammatory bowel disease, or the infectious colitis. In the cases of the infectious colitis, we usually don't need to treat, but in the cases when there is ischemic colitis or the inflammatory bowel disease, we need to treat. Ischemic colitis can present as painless or painful bleeding, painful hematochezia, with mild left-sided abdominal discomfort that can be there. And the thinking of the ischemic colitis, we can take the history of all these things, that usually the patient will be older age, may present with this shock, history of the heart failure, cardiovascular surgery, pulmonary diseases, colon cancer, abdominal surgery, constipation, irritable bowel syndrome, or the oral contraceptive use. So looking at this list, you can think of the ischemic colitis. If the history of any of these is there, you will think of the ischemic colitis. And for the diagnosis, thumbprinting sign may be seen on the CT scan by colon wall thickening. The colonoscopic appearance usually shows the mucosal erythema, friability with exudate. So diagnosis is either with the CT scan or the colonoscopy, but the better or the colonoscopy is having an advantage of the therapeutic intervention to be carried out in this as well. And 10% of those patients with ischemic colitis usually have the severe hematochezia, and recommended treatment is either with the epinephrine injection or the hemoclipping. You can see there is two-edged sword. Patient is having already ischemia, and we are gonna inject the epinephrine, that is a vasoconstrictive agent, but that is the life-saving technology that can be used. While in the infectious colitis, any of the infectious agent like the Campylobacter, Salmonella, or the E. coli, or even the C. difficile may be the causative agents. Significant blood loss is usually rare. If patient is having the severe coagulopathy, they can bleed in the massively even in the infectious colitis. And for the diagnosis, stool cultures or the flex sigmoidoscopy or colonoscopy is needed, and treatment is usually the antibiotics. Endoscopic management is rarely used for the even has no role in lot of the infectious colitis and is rarely used, is not preferred technique. And polypectomy site bleeding, overall it's less common, but usually patient may present with 5th or 7th day of the polypectomy, and that bleeding can happen from 1 to 14 days. Usual presentation, or the most common presentation, is 5 to 7 days after polypectomy. And risk, what are the different risk of the post polypectomy bleeding? That includes if the polyp size of more than 2 centimeters, thick stalk, sessile polyp, or location in the right colon, patient is on warfarin or the heparin, or patient is on the aspirin and the NSAIDs. So here you can see there is a big list of those risk factors that can lead to the post polypectomy bleeding. And we do perform the urgent colonoscopy in the patients with the ongoing active bleeding, and then we can see the major stigmata of hemorrhage at the site of the bleeding. In patients, the Doppler ultrasound probe can be used to detect the underlying arterial blood flow and need the endoscopic hemostasis if redo procedure is needed. And again, if we are performing the redo of those post-polypectomy bleeding side, we may perform the hemoclipping with or without the epinephrine injection. Here this is the polyp removal site, and that has bled. The bleeding has occurred 7 days after the snare polypectomy of a large pedunculated bleeding. You can see the non-bleeding visible vessel. Here it is non-bleeding visible vessel. We will perform the hemoclipping only. But if that is not very clear, pretty clear, we will need an epinephrine injection in the surroundings and then the hemoclippings. Radiation proctitis. Patient may present with the bleeding or the hematochezia and with the history of the radiation for some other reason, like the prostatic malignancy, like the ovarian malignancy. Patient has need for the radiation, or the colon also comes in the radiation pathway. And here you can see the endoscopic view of the radiation colitis. Whole of the mucosa seems to be erythematous with the whitish exudate. This is whitish exudate, and here the erythematous more red and friable mucosa. Telangiectasias. These are basically the vascular anomalies that bleed, and flexible sigmoidoscopy or the colonoscopy shows a friability and sometimes ulcerations. And treatment is usually avoidance of those, the aspirin, NSAIDs. You need to give the patient the high risk or the consumption of the high fiber diets, iron supplements, and 5 amino salicylic acid, that is mesalamine, sucralfate, or the glucocorticoids are usually not prescribed but may be prescribed if needed. Thermal therapy is usually successful for the telangiectasias. Internal hemorrhoids. You can see those internal hemorrhoids on the proctoscopy or the anoscopy, but the colonoscopy with the colonic preparation may also be used if patient has a history of the severe hematochezia or the fresh bleeding PR has been enough. Then we will perform the colonoscopy to look for the internal hemorrhoids. And treatment of the hemorrhoids is usually with the fiber supplement, stool softener, lubricants, rectal suppositories, warm sit baths, anoscopic therapies like the injection, sclerotherapy, rubber band ligation, or the cryosurgery. Rubber band ligation and the sclerotherapy are commonly used, but the cryosurgery or the photocoagulation or the direct current electrocoagulation is less commonly used. Anal fissure. I'm just giving those overview of these things, like the hemorrhoids, like the anal fissure, like telangiectasia, because hemorrhoids, anal fissure, telangiectasia, or the rectal varices or the wart, or you will be discussing them in detail with the surgical team. Anal fissures usually presents with the painful bleeding, and treatment focuses on the healing of the anal ulcer rather than using the specific hemostasis techniques. So calcium channel blocker, 2% diltiazem cream, or the fiber supplement, stool softener, sits bath usually heal the most of those fissures. Ectopic varices in the rectal mucosa can be seen on the sigmoidoscopy. 60% of the patient with the history of the esophageal varices also have the rectal varices. Rectal varices, similar to the esophageal varices, needs the sclerotherapy, band ligation, or the portosystemic shunting if that is secondary to, and if that is secondary to the CLD. Now going on to the solitary rectal ulcer. Solitary rectal ulcer on the multiple panelless rectal ulcers, and they are the third most common cause of the severe hematochezia and developing within inpatients. And on colonoscopy, ulcers are the chronic, appearing large, single or multiple, and can be treated endoscopically. The patients with inpatient hematochezia from the rectal ulcer have higher rates of rebleeding than those present from the home. And the solitary rectal ulcer can also be misleading, looks like malignancy as well. Here you can have a look of a solitary rectal ulcer. This is our scope. Why we are seeing the scope? Because that is retroflexed. If you are retroflexing, means the tip of that scope is looking back towards the scope itself, as we are seeing here. So on the retroflexion you can see here it's a bleeding site, and that seems like an ulcer. Ulcer is a breach in continuity, so that can also be one of the cause of this bleeding and needs to be treated endoscopically. And endoscopic treatment options we have already discussed in detail, we can use as and when needed. So I hope you have understood from this presentation, and just don't worry about if that seems to be much more than what you can think of. It is always helpful if you think this is slightly higher than what you are going through. I hope you have understood. So every expert in anything was once a beginner. Just don't worry, be relaxed, and thank you.